So welcome Dr. Mikhail Kosiborod. He's a cardiologist and we would love to hear from you. He's the Director of Cardiometabolic Research and Co-Director of the Haverty Cardiometabolic Center of Excellence at St. Luke's Mid-America Heart Institute. He's also the Professor of Medicine at the University of Missouri, Kansas City. He received training in clinical research, epidemiology, and health policy through the Robert Wood Johnson Clinical Scholars Program, as well as the clinical training in cardiovascular medicine at the Yale University School of Medicine. Dr. Kosiborod is an internationally recognized expert in the field of diabetes and cardiovascular disease, cardiometabolic, cardiorenal syndromes, as well as quality of care and outcomes. He has authored and co-authored over the 200 peer-reviewed publications, including scientific statements and position statements. He's involved in the leadership of multiple clinical trials and multi-centric registries, and is currently the principal investigator of several investigator-initiated multi-center trials in diabetes and cardiovascular disease. Thank you, Dr. Mikhail, for sparing your valuable time to be with us. We are poor endocrinologists, diabetologists, and would have loved to be cardiologists, but somehow CVOTs have made our dream become possible because we are trying to become diabetocardiologists. Over to you, Dr. Mikhail.
Well, thank you very much, Rajiv, Guillermo, Sanjay. It's a real pleasure and an honor for me to be here with you today. What we're going to do is focus now on the cardiovascular aspects of diabetes management. The topic that I'm going to concentrate on today specifically is sodium glucose cotransporter 2 inhibitors and cardiovascular outcome trials, the current perspectives and future potential. And that's, of course, a very hot topic. As you well know, SGLT2 inhibitors have really had an amazing transformation over the past several years from just another class of medicines to treat type 2 diabetes to something that is rapidly becoming the standard of care and the mainstay of therapy for patients with cardiovascular and kidney disease. So we'll go through the journey of the next 30 minutes, and then I'll be happy to answer any questions. Here are my disclosures. Mostly reflecting clinical trial leadership as well as leadership of multi-center registries. And we'll start with a clinical case. This actually been edited for privacy reasons, but it's a real case that we saw just recently, actually quite emblematic of the types of patients we see at the Cardiometabolic Center at our institution. It's a 50-year-old female that has had type 2 diabetes for 10 years, has sleep apnea and known atherosclerotic cardiovascular disease, actually has premature onset coronary disease with having been diagnosed with non-ST elevation myocardial infarction in 2014. While she was in her early 40s, diagnosed at that time with multivessel coronary disease and required bypass surgery. Currently, she's not having any symptoms of angina. She's being treated with low-dose aspirin and beta blockers, losartan, high-intensity statin, metformin, and a combination of basal bolus insulin. On examination, she has elevated blood pressure of 145/85, pulse of 72. Definitely, there is evidence of obesity with a BMI of 37. She has clear lung fields and normal heart sounds and 1+ edema on exam. And here is the laboratory results with substantially elevated, very poorly controlled hemoglobin A1c of 11.4%, total cholesterol of close to 200 milligrams per deciliter, and an LDL cholesterol of 135 milligrams per deciliter. And looking at the historical data, we can see that it was over 200 prior to initiation of statins. So clearly, the patient has evidence of heterozygous familial hypercholesterolemia, which, along with poor diabetes control, likely explains the premature onset of coronary disease. Triglycerides are also elevated, consistent with not just heterozygous FH, but also mixed diabetic dyslipidemia. There is also evidence of diabetes-related kidney disease with eGFR of 50. No albuminuria data currently available. Elevated liver enzymes, modestly, likely reflecting non-alcoholic fatty liver disease or potentially a component of NASH. And the NT-proBNP is also elevated at 300 picograms per milliliter, with the echocardiogram showing overall preserved ejection fraction, but evidence of structural heart abnormalities, including enlarged left atrium and moderate diastolic dysfunction, suggesting the patient probably has a component of heart failure with preserved ejection fraction, given evidence of edema on exam, elevated natriuretic peptides, and structural heart abnormalities. So the reason this case is so emblematic of patients that we see at Cardiometabolic Center, because there are so many opportunities potentially to improve care. So this patient has poorly controlled diabetes and clearly requires better glycemic control, poorly controlled blood pressure, poorly controlled lipids. The patient has premature onset of coronary disease, so really needs very aggressive risk reduction. There is also evidence of probably previously unrecognized heart failure with preserved ejection fraction, as well as diabetes-related nephropathy. So lots and lots of opportunities to improve care, and probably a very large absolute benefit in being aggressive with multifaceted risk reduction here, because the risk of another event is so high in this particular patient. So let's just remind ourselves what the goal of care is in somebody who has type 2 diabetes. It's very important to keep in mind that control of risk factors is critically important. And the reason it's critically important because our goals are to prolong life, keep our patients living longer, but also as importantly to improve the quality of life. And this is best accomplished by preventing the most common and morbid complications and managing aggressively very common and morbid complications of type 2 diabetes, which by far the most common and morbid complications are cardiovascular and kidney disease. Now, we just went through a decade of cardiovascular outcome trials in type 2 diabetes, where this particular field, what we call today cardiometabolic medicine, the intersection of diabetes and heart disease, underwent a dramatic transformation from being one of the least evidence-based fields in medicine to being one of the most evidence-based fields in medicine because of this decade of cardiovascular outcome trials. And if there is one lesson, probably most important lesson that we learned during that decade, is that glucose-lowering medications or medications used to manage type 2 diabetes are certainly not all the same. Even though they all lower blood glucose, they're certainly not the same when it comes to their effect on cardiovascular and kidney outcomes. And of course, sodium glucose cotransporter 2 inhibitors, so SGLT2 inhibitors, is probably the best example of that. Just as a historical note, fluorescein, which is a mixed SGLT1/2 inhibitor, was discovered about 150 years ago and was actually extracted from the bark of the apple tree root. It was initially tested in the 1930s and found to cause glucosuria and lower blood glucose, but was never used clinically because of poor absorption and lack of selectivity. But ultimately, that led to clinical development of well-absorbed and highly selective SGLT2 inhibitors, with the dapagliflozin initially being approved for type 2 diabetes in European Union in 2011, followed by Canagliflozin in the United States in 2013. Now, I'm not going to spend a lot of time talking about how SGLT2 inhibitors work. I suspect most of you know this very, very well. They block sodium glucose cotransporter 2 in a proximal tubule, a cotransporter that is responsible for the absorption of glucose and sodium. And this, of course, results in glucosuria, as well as at least transient natriuresis, increased fractional excretion of sodium. And these relatively simple and straightforward actions actually result in a cascade of subsequent physiologic and metabolic changes, which likely explain both the cardiovascular and the kidney benefits that we've observed, in addition to glucose lowering with these agents of the past 6-7 years in cardiovascular and kidney outcome trials. So we will start with type 2 diabetes trials, because that's where it all started with SGLT2 inhibitors. They were initially being developed as medications to lower blood glucose and hemoglobin A1C in type 2 diabetes. And as I mentioned before, were mandated by the US Food and Drug Administration to make sure that medications being developed for diabetes are safe from cardiovascular standpoint. And what we observed in cardiovascular outcome trials of sodium glucose cotransporter 2 inhibitors was quite remarkable. While the primary endpoint in majority of those trials were MACE, or major adverse cardiovascular events, which are mostly atherosclerotic events like myocardial infarction, stroke, and death from cardiovascular disease, heart failure hospitalization was an adjudicated secondary or exploratory endpoint in majority of those trials. And because of that, we rapidly found out that patients treated with SGLT2 inhibitors in those cardiovascular outcome trials experienced a robust and highly consistent reduction in the risk of hospitalization for heart failure in excess of 30%. It's a very large and highly significant effect on prevention of heart failure. It's important to note that majority of patients in these trials, and you can see all of these trials listed here, there are 4 cardiovascular outcome trials and 1 kidney outcome trial, actually, which is credence, across 4 different medications in the class, empagliflozin, dapagliflozin, canagliflozin, and orforgliflozin. And there was a lot of variation in these trials in terms of cardiovascular risk. Patients were generally at much lower risk. In Declaratimi 58 trial of dapagliflozin, much higher cardiovascular risk in EMPA-REG outcome, and the Verges CV with EMPA and orforgliflozin. And also there was a gradient of kidney risk as well, relatively low kidney risk in Declare with very high kidney risk in credence. But despite the fact that there was a gradient of cardiovascular and kidney risk, majority of patients in these trials did not have previous history of heart failure. So what you see here is actually a heart failure prevention signal, not a heart failure treatment signal. And it's a very strong signal across different medications in the class and regardless of underlying cardiovascular and kidney risk. The reduction in heart failure hospitalization is very, very consistent and very large numerically. And the second signal that emerged was actually prevention of diabetes-related kidney disease. And again, we see the same exact story, regardless of underlying kidney or cardiovascular risk and regardless of the medication used in the trial within the class, there is a very robust and highly significant reduction of nearly 40% in hard kidney events within a relatively short period of time. Now, as you can imagine, it made sense that once we saw these 2 very strong signals in prevention of heart failure and prevention of kidney disease progression, the clinical trialists are going to ask a question that if these medications are so effective in prevention of heart failure, can they actually be used in the treatment of heart failure as well? And because there was no relationship between all of these cardiovascular and kidney benefits and baseline hemoglobin A1C, the second question that was being asked is, if they are effective in treating heart failure, would that actually translate even to those patients that don't have diabetes at all? So that led ultimately to outcome trials in patients with heart failure. And the first of those was DAPA-HF. That was a landmark clinical trial in heart failure because it was the first to test SGLT2 inhibitor dapagliflozin in patients with heart failure and reduced ejection fraction of less than 40%, in patients that were symptomatic and had known diagnosis and known history of heart failure with reduced EF. And what we saw was an answer to the question whether SGLT2 inhibitors can also treat heart failure, not just prevent it, was a resounding yes. There was a very robust and highly significant reduction in the primary endpoint of cardiovascular death or worsening heart failure in favor of dapagliflozin over placebo, a 26% relative risk reduction, highly significant p-value, and a very low number needed to treat. That benefit emerged very early, and we'll come back to that. And it was driven by benefits on both components of the composite primary endpoint. There was a 30% reduction in worsening heart failure, mostly heart failure hospitalizations, and there was an independently significant reduction in cardiovascular death of nearly 20%. Now, I mentioned before that the benefit emerged very early, and we actually subsequently did analysis demonstrating just how early this happens. What you see here is a primary endpoint in DAPA-HF trial plotted as a solid blue line as a hazard ratio for the primary endpoint, and you can see that the benefit is almost instantaneous. The hazard ratio is below 1 almost within a day or 2 after randomization, but becomes statistically significant after 28 days. indicating that unlike with many other cardiovascular agents that we've seen in the past, the benefit of SGLT2 inhibitors happens extremely quickly. The answer to the second question, whether these benefits, if they exist, would actually translate to even patients that don't have diabetes at all, was also a resounding yes. In this analysis that we subsequently published in JAMA from DAPA-HF trial, we demonstrated that the benefit of dapagliflozin, again shown here as a solid black line with a hazard ratio well below 1, that benefit is consistent regardless of baseline hemoglobin A1C across the entire continuum, whether hemoglobin A1C is completely normal, in a pre-diabetes range or in a diabetes range. And that's also true for the cardiovascular death benefit as well. Now, importantly, it was not just a benefit of SGLT2 inhibitors that was clearly observed in patients with heart failure, but they were also found to be well tolerated and generally safe. There was no imbalance in the DAPA-HF trial in volume depletion or kidney events. In fact, doubling of serum creatinine was significantly lower with dapagliflozin versus placebo. There was no imbalance in amputations or hypoglycemia. There were only 3 cases of diabetic ketoacidosis in a trial of almost 5,000 patients. And the total number of serious adverse events was actually significantly less with dapagliflozin than it was with placebo. So not only was dapagliflozin highly efficacious, but it was also safe and well tolerated. These data have now been confirmed in a second large outcome trial on heart failure with reduced ejection fraction, EMPEROR-reduced. As you can see, the effect on the primary endpoint here was almost identical to the one we saw in DAPA-HF, 25% relative risk reduction, again, highly significant and emerging early after randomization. And we also saw very similar data with the SOLOIST trial with a mixed SGLT1/2 inhibitor, sotagliflozin. Now, this trial was done not just in patients with heart failure, but those that were either in a hospital with heart failure or just recently discharged, so a more acutely ill patient population with heart failure. And again, we see a substantial, robust, and highly significant reduction in an endpoint of total cardiovascular death, heart failure, hospitalization, or urgent heart failure visit of more than 30% with a highly significant p-value, and again, very early separation of curves. And it's because of these trials that SGLT2 inhibitors have now transitioned from being medications to treat diabetes to medications that are becoming pillars of disease-modifying therapies in heart failure with reduced ejection fraction. European Society of Cardiology guidelines just came out at the annual meeting about a week ago, and we now have a class 1 indication for SGLT2 inhibitors in treating patients with heart failure and reduced ejection fraction, along with other well-established medications for heart failure management. And in fact, it's been shown in this particular publication in The Lancet a year ago that if you have a patient who's aged 65 years or older and has heart failure with reduced ejection fraction, if you treat that patient according to the guidelines with all of the disease-modifying therapies, including SGLT2 inhibitors, you can give an average patient like that over 6 years, additional 6 years of life. And what we know from the trials is that not only will these patients live longer, but they will feel better as well. So it's really remarkable effect, remarkable benefits that you can give to your patients with heart failure. Now, it's not the end of the story with SGLT2 inhibitors in heart failure as a fundamental disease-modifying therapies in this disease state. It's actually just the beginning of the story because there are lots more trials that are going on in heart failure with this class of agents, including in heart failure with preserved ejection fraction. I will talk about EMPEROR-preserved in a minute. That's a trial that just got presented to the European Society of Cardiology, deliver with dapagliflozin in this patient population with preserved EF heart failure. Is still ongoing and hopefully we'll be reporting shortly. There are also trials in patients that are in a hospital with heart failure, including MPulse with empagliflozin and DAPA-HF with dapagliflozin. DAPA-ACT-HF with dapagliflozin and several others looking at health status, symptom burden, and exercise function. Now, I'm briefly going to mention the kidney outcome trials as well, because I think they certainly deserve it. As I mentioned before, the 2 signals that emerged were heart failure and kidney disease. This, of course, started with Credence, which I mentioned previously. It was a kidney outcome trial of canagliflozin in patients specifically with diabetes-related kidney disease. that demonstrated dramatic 30% reduction in the primary endpoint that included hard kidney events, such as substantial reduction in kidney function, a progression to end-stage kidney disease, initiation of dialysis of kidney, or cardiovascular death. We also now saw in a DAPA-CKD trial that included patients both with and without diabetes and chronic kidney disease, even a more substantial, almost 40% reduction in kidney endpoints in the DAPA-CKD trial. And in that trial, there was no difference in the benefit, regardless of whether patients had diabetes or not, similar to what we saw in heart failure. Remarkably, in the DAPA-CKD, there was also more than 30% reduction in death from any cause in this population of patients with chronic kidney disease, which I don't think has ever been seen with any other class of medications in a CKD population. And then the question that comes up next is what is in the future for SGLT2 inhibitors? Are we now done? Have we completed this transition of this class of agents from medications for diabetes to cardiorenal drugs that are going to be used for management of patients with heart failure in CKD? Is there actually more that we can do with that class? And to reflect on that, I actually wrote this editorial in Circulation a few months ago that I called Diamonds in the Rough. And the reason I called it Diamonds in the Rough for SGLT2 inhibitors is because, in my opinion, I think this is a class of agents that are going to continue to keep on giving because there are many, many additional disease states where SGLT2 inhibitors can actually be of potential benefit. And I summarized that in this table where I showed some of the things we already demonstrated, such as the benefits in people with type 2 diabetes, heart failure with reduced ejection fraction, and chronic kidney disease, but also benefits that are being actively explored as those patients with heart failure and preserved ejection fraction, what's called a black hole of cardiology, because for decades we have not been able to find efficacious medications for those patients that represent half of the patients with heart failure. Those that are in the hospital with decompensated heart failure, also a very high risk population for which there are relatively few efficacious treatments, patients after myocardial infarction. And interestingly, also, these medications being explored now in COVID-19, and I will come back to that. But there are lots and lots of additional opportunities for disease states where these medications can be effective. And so we need to make sure we continue to explore it. Coming back to heart failure with preserved ejection fraction, as I mentioned before, Emperor Preserved was just presented at European Society of Cardiology about a week ago. And what we saw is for the first time, a efficacious medication that substantially reduced the risk of cardiovascular death or worsening heart failure in a population of patients with heart failure and preserved EF, where for decades we have not been able to find medications that are effective and safe. So this is likely going to also change guidelines for heart failure and preserved ejection fraction and change how we treat that very important patient population. What about COVID-19? Well, we did investigate that in the DARE-19 trial with dapagliflozin. Interestingly, what we observed in DARE-19 was a potential signal towards a benefit in preventing organ failure and death in patients that are hospitalized with COVID-19, regardless of whether they do or don't have type 2 diabetes. Unfortunately for the trial, fortunately for the patients with COVID-19, during the course of the trial, the event rates of organ failure and death decreased substantially because of improvements in standard of care. And so we did not collect as many of organ failure and death events as we were planning on. And so the trial ended up being somewhat underpowered for this primary endpoint, but it certainly raised the hypothesis that dapagliflozin may potentially provide benefit in patients hospitalized with COVID at risk for organ failure or death. And that's a hypothesis that clearly needs to be explored in additional trials, and it is being explored in additional trials, as I will show you shortly. Now, very encouragingly and reassuringly, for this primary endpoint, there was a directional signal in favor of dapagliflozin for every component of that primary outcome, including respiratory failure, cardiovascular failure, and kidney failure, as well as death from any cause, which again points us in directions that these medications may offer potential benefit in COVID-19, and that needs to be explored so we have a definitive answer in future trials. As you may well be aware, there were lots of concerns raised about SGLT2 inhibitor use in COVID-19 situation, and in fact, there were professional societies that were issuing recommendations to stop SGLT2 inhibitors in anyone who gets hospitalized with COVID-19. But in this trial, there are 19 in 1,250 patients across 95 hospitals in 7 countries. We saw very favorable safety profile. Dapagliflozin was actually very well tolerated, and the number of serious adverse events, including those that resulted in death, were numerically less with dapagliflozin than placebo, as well as adverse events that led to discontinuation of study medication, those that led to acute kidney injury. All of those were numerically less likely to occur with dapagliflozin than with placebo. We only saw 2 cases of DKA. Both of those occurred in patients with prior history of type 2 diabetes, and we had very aggressive proactive surveillance program for DKA in a DARE-19 trial, where everybody had to be tested for acid-base status on a daily basis if they had diabetes. And despite that very aggressive mandatory surveillance program, we only identified 2 cases of DKA in patients with diabetes that were treated with dapagliflozin. Both of these were non-serious and non-severe and rapidly resolved after discontinuation of study medication. So overall, what we saw was a very intriguing hypothesis-raising results. And I'm pleased to say that the recovery investigators in the United Kingdom decided to take this on and do another trial with SGLT2 inhibitors based on what we observed in DARE-19. They're actually using empagliflozin, and they just added a new arm to the recovery trial, which is going to further explore whether these medications can provide benefit in COVID-19. Now, let's come back after this amazing journey. Let's come back to the patient that we started with. This patient, as we talked about before, had lots of opportunities for quality improvement and care improvement, and patient was in fact started on a potent long-acting GLP-1 receptor agonist and SGLT2 inhibitor, and also PCSK9 inhibitor, as well as amplification of antihypertensive therapy. Patient responded remarkably well to this medication regimen, and actually were able to completely down titrate and then stop insulin altogether. 12 months later, this patient now has a hemoglobin A1C of 6.7% from 11.3% where we started off insulin. BMI has been dramatically reduced from 37 to 27 with a 50-pound weight loss. Total cholesterol and LDL cholesterol are now very well controlled, as is the blood pressure. And most importantly, patient really had a dramatic improvement in her quality of life, prompting additional lifestyle interventions. Now, the last few minutes, I'm just going to reflect on one of the biggest issues that we have in the field today, which is that we've generated all this amazing data. And the data now has been incorporated firmly in international guidelines, both diabetes guidelines and cardiovascular guidelines, clearly emphasizing the use of cardioprotective agents such as SGLT2 inhibitors, as well as GLP-1 receptor agonists in the care of patients with diabetes and cardiovascular disease. But the problem that we have, at least in the US, and I suspect in most of the world, is implementation of those guidelines into clinical practice. In this publication a couple of years ago from a large registry in the United States across 120 centers, we showed that in patients that have type 2 diabetes and atherosclerotic cardiovascular disease, less than 7% actually getting optimal guideline-directed care, less than 10% are receiving SGLT2 inhibitors, less than 8% are receiving GLP-1 receptor agonists, and even medications like high-intensity statins and ACE inhibitors and ARBs are underused in a very large proportion of populations that could really benefit from these treatments. So why is that happening? And at least in my humble opinion, one of the key reasons is that we don't have effective clinical care models that really focus and emphasize prevention. And we decided to change that at my academic institution, St. Luke's Mid-America Heart Institute, and we built a Cardiometabolic Center of Excellence about 3 years ago, where we use a team-based approach through coordination of care by nurse coordinators and nurse navigators. That's actually championed by preventative cardiologists, but done in collaboration with our endocrinologists and primary care doctors to try to provide multifaceted and very aggressive risk reduction in this high-risk patient population. What we showed is that within a very short period of time, within just 3 months, 3.5 months, we see with this approach a dramatically greater improvement in weight and hemoglobin A1C, blood pressure and cholesterol. We also see substantial reductions in insulin requirements, About half of these patients are on insulin at baseline, and we see nearly 50% reduction in insulin requirements, and many patients coming off insulin altogether while improving their glycemic control and all the other risk factors. And we also see dramatically higher use of guideline-directed therapies, including cardioprotective agents such as SGLT2 inhibitors, GLP-1 receptor agonists, but also ACE inhibitors and high-intensity statins, and a substantially higher, nearly 20-fold higher use of this composite metric of optimal guideline-directed therapy. So we know that by changing the care delivery model, we can really impact in a positive direction the care of this patient population. And we're now taking it on the road. About a year ago, we launched a non-for-profit called Cardiometabolic Center Alliance, where we help other healthcare organizations around the country, here in the United States, build their own cardiometabolic centers of excellence based on our model, with the chief goal of improving the quality of care and outcomes in this very high risk and vulnerable patient population. So with that, I thank you for your attention. As I said before, it's been an amazing journey over the past decade, from where we started, where we had very little evidence, to where we are now, where we have lots of evidence. The key goal now is to make sure that we translate that evidence into clinical practice, so the care of our patients and their outcomes improve as well. Thank you very much.
Thank you, Dr. Mikhail. So go ahead, Sanjay.
Yeah, no, thank you very much, Dr. Mikhail. And the session is open for questions. Please do write the questions in the chat box, and Rajiv or I will be happy to read it out to Dr. Mikhail.
Mikhail, one question from my end. Heart failure with preserved ejection fraction is a kind of enigma in diagnosis. So how does a clinician actually diagnose, or how does he at least identify those people who are at risk for HFpEF? HFrEF is quite clear. HFpEF, how does he diagnose it?
Right. So excellent question, and obviously questions that gets raised very frequently. And you're right, the diagnosis sometimes can be a bit trickier with heart failure and preserved ejection fractions and heart failure with reduced ejection fraction. But remember that heart failure is a clinical syndrome first and foremost. So the diagnosis is based on symptoms and physical exam findings. And so the symptoms and physical exam findings in heart failure with preserved EF are the same as they are in heart failure with reduced EF. It's breathlessness, exertional intolerance, exertional fatigue, edema, elevated jugular venous pressure, evidence of congestion. So it's the same as heart failure with reduced EF in terms of physical exam and symptoms. The biomarker and imaging parts of the diagnosis are somewhat different. Patients with heart failure and preserved ejection fraction tend to have somewhat lower natriuretic peptide levels than those with reduced EF. But certainly if you have elevated NT-proBNP or BNP, it's highly suggestive that the patient has congestion and probably has HFpEF. And then imaging, of course, is very important as well. So echocardiography can be very useful. The thing to keep in mind, of course, that in HFpEF, you're not necessarily looking for abnormalities in ejection fraction. The ejection fraction can be completely normal. But there are usually structural heart abnormalities that are present in that setting, and those include left ventricular hypertrophy, they include left atrial dilatation, they include diastolic dysfunction and elevated pulmonary pressure. So if you have a combination of things where you have symptoms, you have a syndrome, clinical syndrome, that's consistent with heart failure, and then you have either elevation in natriuretic peptides or evidence of structural abnormalities, or a combination of those things, that's very, very highly suggestive, and in most cases would be diagnostic of HFpEF.
There's a question by Dr. Guillermo, and Dr. Guillermo would like to know, in HFrEF patients treated with the SGLT2 inhibitors, what happens to the ejection fraction and how much improvement should we expect?
It's a great question, Guillermo, and I think it's very important to keep in mind that in heart failure and reduced ejection fraction, there is definitely, and this is a very interesting phenomenon, but there is definitely a disconnect between change in ejection fraction with various treatments and clinical outcomes such as survival, hospitalizations, or quality of life. In fact, it's not a given necessarily that you will have an improvement in ejection fraction after you start neurohormonal medications like RAS blockers or beta blockers, or sacubitril/valsartan, or for that matter, SGLT2 inhibitors. Some patients do and some patients don't. But even patients, the fact that you don't have an improvement in ejection fraction does not mean that you're not going to get a benefit in survival, hospitalization, reduction in hospitalizations, and quality of life. In fact, as some of you may know, the medicines that clearly improve ejection fraction and HFrEF, such as inotropes, actually hastened death. They actually make people die faster, despite improvement in ejection fraction. So there is definitely a disconnect there. We don't have extensive data on ejection fraction, so we stopped, in large outcome trials, we stopped actually measuring ejection fraction in follow-up as a result of that, because we think of it as a surrogate outcome that doesn't correlate necessarily with survival, hospitalizations, and quality of life. And so there is not a structured reassessment of ejection fraction in most trials. We do know, however, that SGLT2 inhibitors in several smaller mechanistic studies have a favorable effect on left ventricular remodeling. It's not necessarily improvement in ejection fraction, but it's reduction in left ventricular volume, so reduction in the size of the left ventricle, as well as improvement in hemodynamic parameters as well. We just completed a trial with Canagliflozin, actually, one of our investigator-initiated trials in patients that have heart failure with either reduced or preserved ejection fraction and have an implantable pulmonary artery pressure sensor that can give you pulmonary pressure readings on a daily basis. And what we showed is that over 12 weeks, there is a very rapid improvement in pulmonary pressure with Canagliflozin as compared with placebo, and that starts happening within 1 week. So there is definitely change in hemodynamic parameters, and left ventricular remodeling goes in a positive direction, but we don't have definitive data on what actually happens with ejection fraction.
I have a question for you. We have the CV outcome trials for most of the new molecules, right? From incretins, GLP-1, DPP-4, SGLT2 inhibitors. But majority part of the world still continues to use the older molecules like SUs and others. If you have to revisit them again in today's time, what do you think you would predict the CV outcome trials would be for the older molecules? I mean, would they be just CV safe, or would you see that there could be some benefit in using these molecules even today with established cardiovascular disease or patients with cardiovascular risk?
Well, with sulfonylureas, actually, we don't have to guess anymore because we have a trial that actually gives us the answer. And that is the Carolina trial that was presented at the European Association for Study of Diabetes in 2019 that directly compared glimepiride, which is one of the second generation sulfonylureas, with linagliptin, which is a DPP-4 inhibitor. Now, there was no placebo group in that arm, but we already had a previous trial called Carmelina with linagliptin compared that to placebo, and we knew that linagliptin is no different from placebo when it comes to cardiovascular outcomes. So it's safe, but provides no benefit. And so comparing glimepiride to linagliptin is essentially comparing glimepiride to placebo in that regard. And we, again, saw no difference in the cardiovascular outcomes in a Carolina trial between glimepiride and linagliptin when it came to major adverse cardiovascular events or heart failure, for that matter. So what we can say, I think, certainly with glimepiride and probably the rest of the sulfonylureas, is that they don't increase cardiovascular risk, but they don't reduce cardiovascular risk. You essentially get no benefit on any cardiovascular outcomes with either DPP-4 inhibitors or sulfonylureas. There was a difference in that trial in hypoglycemia rates, as you would imagine. There was much higher hypo rate with glimepiride as compared with linagliptin, but otherwise there was really no difference between the two drugs. So I don't think we have to guess. I think we can pretty definitively say that with SUs, if we did a cardiovascular outcome trial today with different set of SUs, probably what we would see is no benefit because we already have that evidence from Carolina. Metformin, of course, continues to be very controversial. Because we don't have any contemporary cardiovascular outcome trials with metformin. It would be a very difficult trial to do in patients with diabetes because it's universally recommended by the guidelines. And so it's used in the vast majority of patients with diabetes. It's very hard to give somebody placebo in that regard. But there is a trial going on actually in the United States in the Veterans Administration system that is comparing metformin to placebo. It's a cardiovascular outcome trial, and it's not being done in people with diabetes, but in those with pre-diabetes and established cardiovascular disease. So hopefully within a few years, we will have more of a definitive answer on metformin as well.
Okay, we have one last question. Raji, you want to read out? Dr. Guillermo has put another question in the chat.
It's about data on AFib, and by reducing volume, do you expect a reduction in AFib? And I one question for Dr. Mikhail. The CHARM study on candesartan told us that people with diabetes with preserved ejection fraction have worse outcomes as compared to reduced ejection fraction. Is that really so in the real world also, that people with HFpEF fare badly as compared to people with HFrEF?
Yeah, so let me take the atrial fibrillation question first. So, Guillermo, again, an excellent question. And in fact, there is preliminary data suggesting that SGLT2 inhibitors may potentially prevent atrial fibrillation, based on the physiologic rationale that you pointed out in your question, most likely. And that data actually comes from DECLARE trial, where there were several hundred atrial fibrillation events. This was, of course, an exploratory outcome, but nevertheless very important to look at. And in fact, there was a significant reduction in the development of new atrial fibrillation with dapagliflozin as compared with placebo in the DECLARE trial. Now, that should be confirmed in other trials. I think it's a very important outcome to look at. But at least the initial data we have suggests that there may be a positive effect there as well. Coming back to a question, Rajiv, about CHARM, this is a big controversy in the heart failure field. There is a camp, if you will, that strongly believes that patients with heart failure and preserved ejection fraction actually have greater burden of symptoms and functional limitations, that even those patients that have HFrEF, they may have slightly lower mortality and slightly lower hospitalization rates, but they actually are more functionally and symptomatically impaired. And there is definitely evidence, not just from CHARM, but from other trials as well, to suggest that that's the case. So that's a patient population that really needs efficacious medications that not only improve mortality and hospitalization rates, but improve the quality of life as well.
Thank you very much, Dr. Mikhail. I think, and for want of time, we would love to hear you more and more, but we'll have to end the session. But compliments from the team IDEC. Excellent lecture, and it was a lot of take-home points that we could really get from your lecture. Thank you once again for being part of this meeting. Thank you.
My pleasure. Thanks so much for having me. It was an honor.